Good morning, everybody. Today's topic is about Schwind ATOS. As we already know, we're now moving towards customized treatments to specifically correct ocular aberrations. And if we look at this refractive surgery revenue by product category, we know that femtosecond lasers, it occupies a whopping 44%. And although very close, the lenticule extraction procedure rates are very close to the flap procedures. So going back to the inception of Schwind, it starts all the way from 1992, and it was only up until 2007 when we had the Schwind 500. And then in 2013 we had the 1050 RS, and now we have the we have the Schwind ATOS. So coming to the Schwind ATOS suite, it has a concept of low energy of femtosecond lasers. That means it uses high energy pulses, which is in the range of 4 to 15 microjoules, but it has low frequencies, and it causes cavitation bubbles which causes it to expand, and it disrupts the tissue by mechanical forces. So this was how it was conventionally done compared to what is now presented by Schwind, which is the lower energy model. That is, it uses a high pulse repetition rates and low energy pulses. So that means that the tissue cuts are more precise. So the ATOS intelligent femtosecond laser can be used for both the lenticule extraction and the flap creation. So the diagnosis, so we first calculate the pupil center and the corneal vertex. That's measured by, can be either measured by the Schwind series or the MS39. And the planning is next done by using this data from Sirius or MS39. So on the system, we can see that the green crosshairs that are present, so it tells us about the torsional deviation. And then we have the eye tracker that detects and displays the pupil center, and we have the yellow crosshairs that tells us about the target position. That tells us about the offset from the pupil center to the corneal vertex. So the cyclotorsion is achieved by importing the data from MS39, as I mentioned. So the SEC is a static cyclotorsion check that's acquired for accurate centration. So only after that is done, we will be able to enter the data on the ATOS platform. So here we can either plan for the flap-based or the lenticule-based. So after entering the patient's data, we can enter the lenticule parameters or the flap parameters based on the surgeon's choices. So here we see there are certain parameters that are in yellow and certain in gray. So the ones in yellow are the ones that can be edited. That is the patient's refraction, the pachymetry, and the K1, K2, which is most of the times that is taken from the MS39. So here we see a surgical demonstration. The lenticule dissection is being done, and the lenticule will be then extracted. So the energy offset, it varies from 90 to 120 nanojoules. So it's seen here in this picture. The edge cut is around 95, and the anterior cut is about 85. Posterior cut is about 85 that is kept in this machine. So here is just a case example where we see the pre-op, which was about minus 5.75, minus 1.75 in the right eye. And post-op, we have a cylinder of minus 0.5 with 180 with good visual outcome, 6/6. Similarly in the left eye as well. And this is another case study where we have a 24-year-old male who's come for a refractive surgery, and the refractive error is somewhere between minus 3.25, minus 1.25 in the right eye, and minus 4, minus 1.25 at 6/6 in the left eye. We went ahead and we did the Schwind ATOS. So here we can see. But what happened is the patient moved just before the incision creation. So after the OBL subsided, what we did was we shifted back to the OT, and we selected the incision only mode after redocking, and then we completed the surgery. So as we can see here, there are many options that are available. The standard treatment, or start treatment from cap or incision only, and we opted for the incision only mode, and after redocking we were able to complete the procedure. So here we can see just the incision was created, and the lenticule was, we have been able to extract the lenticule. So post-operative outcome was still 6-6, and this is the ASOCT minimal interface edema. So that was the case that we encountered with Schwind ATOS.
I think the one thing to remember with the Schwind is it looks decentered, but it isn't. The camera is not coaxial, so don't get alarmed. Everyone would be thinking what's going on in those videos. Please,
So,
question from
I
the
tried
audience.
doing incision only in my case, where OBL was patient, because of some vacuum issue, the suction was lost. But I got into the wrong plane, I just could not finish it, and I just abandoned and did PRK later. But you have shown that you waited for OBL to go, then decentered, and then probably that's the trick to do it. Because when I did without OBL, I had to stop the tracker because it was not tracking, and OBL was there, and I did incision, and as I expected, it was not in the exact plane.
I've had a similar case. This is where we have learned the lesson from, where we just right away went ahead and did a incision only. But whenever there is OBL, you have to understand that it doesn't allow the auto centration along with the MS39, so that you're just doing it randomly, like you're just thinking that this is the center and you go ahead and make an incision. That's when the right plane is not created. You have to struggle, find the anterior and posterior plane, or sometimes you're not able to. So since then, whenever there's a suction loss, we always wait for the OBL to disappear and then only redo it.
How long you wait, an hour or so?
At least 2 hours. At least 2 hours.
Is there any particular step in which you would decide that, okay, I can continue, or should I wait 2 hours? Or sometimes we say that, no, we have to wait for a month or two. We postponed it.
If there is a suction loss in somewhere middle of the anterior cut, which is the cap cut, then I think that's when you don't go ahead and redo any surgery and you convert it to PRK.
Okay.
Traditionally, you're supposed to wait for a month or two, but what we do is we start our patients on steroids, high-dose steroid, and we wait for a week or 10 days, and once the edema is subsided, we repeat a topography. If we see there is no change in the topography before the first surgery and today, let's say after 10 days, then we go ahead and do a PRK at that point of time. Because a lot of patients, sometimes they don't want to wait, and we have to come back with answers. And I have had a suction loss, and if I'm abandoning the surgery for PRK, I iron the cap so that little bit interface edema will go away, and that's when
So if it's in the initial step, we can actually continue.
Yeah. So every machine is different. Smile has step-by-step circle software. ATOS has 3 steps. You can either redo the entire surgery, you can only create the cap, or incision.
Oh, nice.
So you have to understand the machine, and at this point of time,
Yes.
Silk doesn't have a rescue mission, so that's the.
And how much seconds is the ATOS?
The laser time is around 30 seconds, but the docking and everything takes around a minute.
If there are no other questions, then we can end the session. It's been a wonderful discussion. Thank you for being a very